I'm pleased to introduce again Dr. John Devlin from Northeastern University, who will talk about clinical trials for the prevention and treatment of delirium. And again, John is no stranger to delirium research. He has a long history of that, and we're very, very lucky to, I think one of the things that Wes stressed that was really important was the interdisciplinary approach. And so we look forward to hearing John's talk. Take it away.
Thanks very much, Donna. It's a honor and a privilege to be here today. And you know, this boot camp is all about mentoring, right? And it's I just want to acknowledge all my mentors that are on the call here: Wes, Pratik, Sharon, and others. And mentorship never starts; it never stops. And sometimes it's you know, as junior investigators, it's how we you know, get research ideas, you know, help with applications and other related mentorship activities. But sometimes many of us are moving sort of in new areas and asking different questions that we're not used to, or there may be some methods that we're not as familiar with. So, you know, we're a really good, tight community, the delirium world. And I'm just thankful and encourage everybody to, you know, take advantage of all the mentorship opportunities as we just continually ask, you know, important questions to try to make change and improve patient care. I'm going to build on Wes's, you know, really excellent presentation and talk a little bit about some of the best practice considerations and how we may incorporate them in our delirium investigations, whether it's in the ICU or not in the ICU. And you know, delirium research, as whether you're doing, you know, clinical cohort studies or prospective randomized control studies, are a little more challenging probably than they were 20 years ago, because we do have a lot of great information. So we need to be able to, you know, deliver best practices to our patients while we're investigating, you know, potential new interventions. These are my disclosures here. Good. So I'm really going to make three key points about prevention and treatment. As was highlighted, daily risk reduction efforts are the foundation for prevention efforts. Multi-modal protocols, Wes gave the example of the 8F bundle, using primarily non-pharmacologic-based strategies is key to delirium prevention and treatment across all practice settings. And this certainly includes, you know, acutely hospitalized patients for who are geriatric or admitted for surgical procedures, but virtually any population, inpatient or outpatient. And I think another really important theme that Wes highlighted is pharmacologic interventions generally have minimal benefit. And for example, things like antipsychotics really reserving for very short-term use when patients have, you know, important or severe delirium-related symptoms. So we're not using widespread medications really in any population other than to provide supportive care. When we look at delirium risk factors, this is from Dr. Inouye's Lancet review articles. You know, it's important to distinguish risk factors as either being predisposing or precipitating. And obviously modifiability is the big question here. Most predisposing factors, including age, pre-existing dementia, cognitive impairment, a history of delirium, functional impairment, sensory impairment, severity of illness, depression, a history of TIA or stroke, moderate alcohol use. These are things that patients come to, for example, a hospital or with, and generally cannot be changed. Most of our efforts, of course, should be focused on precipitating factors because these are generally more modifiable. You know, I put medications at the top maybe because I'm a pharmacist, but certainly psychoactive medications, particularly sedative hypnotics and opioids, you know, up to 15–20% of older adults chronically take benzodiazepines, for example, anticholinergic medications, corticosteroid medications, particularly at higher doses, and then drugs that we might not think about, like metoclopramide. Medication withdrawal can certainly be a precipitator of delirium, use of physical restraints, bladder catheters, acute physiologic and metabolic abnormalities, for example, lower diuresis, electrolyte abnormalities, new infections, for example, a pneumonia, obviously a long list of iatrogenic events, major surgery, and then, urgent administrations, major trauma. These are all big risk factors. As Wes mentioned, it's really important, whether you're in the ICU or in the post-operative setting, whether you're in a nursing home, it's important to use a standardized approach to mitigate these delirium risk factors on a regular basis. Obviously, in some settings, this might not happen on a daily basis. It's tricky though when if one is going to attempt a say a cohort study evaluating a new delirium intervention. There's many potential sources of biases, and obviously bias is a systematic deviation, the variable of interest. And it's important that we account for delirium risk factors in cohort studies that we might complete. Not doing so, it makes it impossible. For example, if a patient's exposed to a new drug or a new non-pharmacologic intervention in a cohort study, it's impossible to know, by not accounting for some of these risk factors, whether it's the intervention itself or the other factors, absence or non-absence of other delirium precipitating risk factors that could cause the outcome. So this is just sort of a simple model for a patient admitted to the ICU. We know there's these delirium baseline risk factors that need to be considered. A patient, for example, is given a exposure to drug X. The patient, survives their ICU stay and is discharged, and then it's easy to look back whether the patient had delirium during their ICU stay or was delirium free during their ICU stay. Easy to develop a risk ratio for developing delirium with exposure to drug X, and certainly it's easy to account for baseline factors and model those that could account for the delirium presence. Of course, there's lots of issues with this, right? By using simple models like this, what if the patient had delirium on day 3 but wasn't exposed to the drug until day 4? So time really becomes an important factor in these models or cohort studies. And then there could be other confounding things that happen throughout the ICU stay. So what if the patient on day 2 is exposed to a drug X, and on the same day also has new septic shock, potentially greatly increasing the severity of illness? Is it the drug that potentially is going to lead to delirium the next day, or is it new onset septic shock that could be leading to delirium the next day, or a little bit of both? So these models can get a little more complex as you move along. And this is important, accounting for these, particularly in the ICU world. Delirium has been shown to be an independent predictor of death during the ICU in 9 studies. However, none of these studies have looked at daily risk of delirium. For example, a patient A could come into the ICU sick and get sicker over the course of their ICU stay, or a patient B could come into the ICU and actually get a lot better, which is what we're hoping for during their ICU stay. So they could, on day 6 here, which was the day of the onset of delirium, they could have a very different daily severity of illness. And so competing events, for example, if the patient's discharged from the ICU, if they've had coma up to this period, or they actually die, it could preclude the detection of delirium before ICU death occurs. So an interesting paper that came out from Argent Schluter's group was published in BMJ in 2014, looked at this. And so they looked at 1,012 mixed medical surgical ICU patients. 50% developed at least one episode a day of delirium, median duration of 3 days over their ICU stay. The crude ICU mortality was 17% in delirium patients, 7% in non-delirium patients. So this suggests that there's more than twice the risk of delirium Mortality is more than twice as high in patients that experience delirium during their ICU stay. And this is a hazard ratio here. But after adjusting for these time varying confounders, including daily SOFA, which is severity of illness, Coleman ICU discharge, using sort of a Markov marginal instructional model, actually the hazard ratio of ICU mortality in patients with delirium almost completely disappears. And in fact, these investigators found that only 7.2% of the ICU deaths were attributable to delirium. So I realize I'm putting this in the context of ICU studies, but it is important if you're looking at any clinical cohort and looking at post-ICU outcomes, it's important, or any outcomes after, for example, like acute hospitalization or a post-surgical period, to account for daily changes and things that could affect the association between delirium and any of these relevant clinical outcomes. Many of these models, for example, in the ICU, will look at admission service, age, what's the baseline severity of illness? Apache 2 is commonly used. What's the patient's functional status before they came in the hospital, usually with the Charleston Comorbidity Index? Do they have a history of chronic alcohol use, hypertension? So these are some of the baseline factors that we've already talked about. And then some of the time varying one, though, is obviously we want to count for the day of the ICU admission to make sure that the event, i.e. delirium, happens after the intervention. We've talked about daily severity of illness. Is there new things that could increase daily severity of illness, like severe sepsis? Are patients mechanically ventilated? Is there other conditions that might use the study medication? This is from a study looking at benzodiazepines. So were patients highly agitated? Were they in pain? What if propofol was used rather than benzodiazepines? And then, of course, there's other competing medications that might actually reduce delirium occurrence, such as dexmedetomidine. So what's happening in these daily Markov models is you're most interested on say ICU day 2, if the patient is awake and not delirious, what's the risk of them developing delirium on ICU day 3? So you're really interested in this transition from being awake, not delirious, to having delirium. And that's what these models can do. And these are the results of this benzodiazepine analysis. And Pratik Pandharipande published a prior study, Markov cohort study, looking at daily risk with lorazepam. This is with midazolam. And there's a 4% daily risk of transitioning from delirium to no delirium for every 5 milligrams of midazolam administered. So it just shows the risk here and sort of the complexity of cohort studies. And it doesn't need to mean that you need to certainly use daily Markov models such as this, but it does suggest that you need to account for, in a time-dependent fashion, risks in any cohort study where you're looking at an intervention in delirium and a potential outcome. What about randomized control studies? Well, many of the concerns with risk and risk factors sort of are controlled for in a randomized control study. This is a very small pilot study looking at low-dose IV haloperidol to try to prevent the conversion of subsyndromal delirium to delirium in the ICU. And even though this is a very small 68 patient study, this is sort of the classic table 1, and randomization pretty much always works. These patients were very evenly matched, even though it's a very small group of patients. So again, randomization takes care of many of these sources of bias that we have to really worry about in cohort studies. Another type of bias is inclusion bias that is something that is of concern in randomized control studies. And it is important, particularly for something like delirium, where patients may either come in with delirium, they may come in not with delirium, or they may have had a changing state before they're actually randomized into the study to account for all the patients coming into the study. So this is, again, this small Haldol study. We screened 1,358 patients that were admitted to the ICU track them, and then once they developed subsyndromal delirium, but they didn't have delirium, we then randomized these patients into the study. This has been done with many other studies as well. For example, as Wes mentioned, the Mind USA study. And it's really important to control your cohort with delirium studies and not just sort of grab people, screen for randomization, but not know how many patients in your larger cohort were at risk and weren't at risk, because again, it's an important bias. The other problem that we see with many randomized control studies, whether you're in the ICU or not in the ICU, is external validity. For example, in our study, we had 481 patients with subsyndromal delirium. We were only able to randomize 68%. So we had a inclusion rate of enrollment rate of 14.1%, extremely low. There's certainly an increasing number of studies that are focusing on more pragmatic research designs, really trying to reduce a lot of these exclusion criteria where possible, but realizing with pragmatic design, even though you might be able to boost this number and have a much higher enrollment, you're still going to you still are going to struggle at times. Are you going to include patients that might have a confounding disease that could affect the outcome that you're evaluating? For example, acute alcohol withdrawal, or is there a safety concern that could preclude safety issues with the intervention? The last thing I just wanted to make a point with studies is being really making sure you have good stopping criteria. And also, if you have an anticipated safety concern, whether it's bradycardia, say with dexmedetomidine, or sedation with, say, haloperidol, that you don't necessarily stop the patient, remove the patient immediately from the study, and try to mitigate those known safety concerns before you actually stop the study, because that's another big study bias. If there is an important subgroup of patients who may respond to the intervention differently, this is where it may be possible to incorporate stratification prior to randomization. And then if there's a major confounding factor that could influence response to the intervention, this is where you might decide to incorporate a priori subgroup analysis to evaluate the primary outcome difference between these two different patient subgroups. But again, this should all be done a priori. So the next key point that is also relevant to delirium research is the importance of multimodal protocols using non-pharmacologic-based strategies. This is a great review by Tammy Shea for acutely hospitalized older adult medical patients. So orientation, therapeutic activities, provide lighting, calendars, clocks, frequent reorientation, cognitively stimulating activities, facilitating regular visits with family and friends. We'll hear more about that next. Obviously, fluid repletion, early mobilization, regular ambulation, feeding assistance, vision, hearing, and then sleep enhancement. Of course, many of these strategies are well established in most institutions. Because they've been shown through, Sharon's great work with the Hospital Elder Life Program and many other large bundled intervention, non-pharmacologic multimodal bundled intervention, that they dramatically reduce delirium and are beneficial in patients. In this later meta-analysis by Tammy, looking at these bundles, delirium incidence reduced by almost half. This is a really strong signal across all of these different types of interventions in different geriatric inpatient populations. And of course, this is the A to F bundle. It's important, though, when you're doing a randomized study or any cohort, say that your cohort has been with these pharmacologic multimodal delirium reduction protocols have been systematically applied in your study cohort. This is an old study of mine looking at quetiapine in critically ill patients. It was a double-blind, multiply randomized control study, where we did find that delirium resolved faster with quetiapine, but again, extremely small numbers. It's very much pilot. But back in, the late 2000s, 2007, 2008, we didn't have the ADF bundle. We weren't mobilizing patients. Sedating practices were deeper. We weren't thinking about sleep. And so we were using a lot more benzodiazepines. So one could question if a A to F bundle had been applied rigorously in these patients, what would have been the treatment effect and how would quetiapine have worked versus in this study where it wasn't applied. And since then, Wes presented the landmark Mind USA study. The A to F protocol was rigorously used daily in all study patients. So we know this has sort of been removed as a potential confounder. And of course, this was actually a negative study. I think the last thing I just wanted to leave you with is that pharmacologic interventions generally have minimal benefit. And again, we talked about it, they really should be used selectively in any patient population. Despite the fact that Jose Maldonado and all of us, realize the complexity of the neurotransmitter hypothesis of delirium, that there's lots of potential medications we can give to, inhibit dopamine, enhance the cholinergic system, like drugs like ribostigmine, NDMA antagonists like ketamine, alpha-2 agonists like dexmedetomidine, or melatonin agonists like ramelteon and melatonin. But none of these drugs have really panned out, despite a fair bit of extensive research. And it's really dangerous without research to use these drugs. I'm not presenting the study, but many people might remember Argent Schluter's Ribostigmine delirium prevention study that came out about a decade ago in Lancet. And this study had to be stopped early by the DSMB because mortality was increased in these critically ill adults who were receiving ribostigmine to prevent delirium. So again, the rigorous research is so important because of the potential safety concerns with these agents. And just because they look good here does not mean that they're going to pan out as being effective. SRO, Delirium, and others in their Hopkins group have published really a state-of-the-art systematic review of antipsychotic therapy for both delirium prevention in acutely hospitalized and treatment for acutely hospitalized adults. This search ended in July 2019, and I urge you to read this paper. It's two papers that came out, one prevention, one treatment, last year in Annals of Internal Medicine. And across the board, there's just not a strong signal that delirium can be prevented with the use of these drugs across various groups of patients, whether they're in the ICU, pre-surgical, or acutely medical patients admitted to a geriatric. And the same goes, a little bit more data with second generation. So you can see there could be something, but there's a lot of flaws in these studies in terms of the design of the studies, how delirium was evaluated, and the dosing structure of the study. So at this point, there's many recommendations in postoperative patients, ICU patients, not to routinely consider a antipsychotic intervention to try to prevent delirium. And this looks at haloperidol to try to prevent delirium. Again, virtually no difference on mortality. No data with delirium severity or hospital length of stay. This is delirium treatment with haloperidol. Again, no difference. And this does include the Mind USA study. And then when you look at second generation antipsychotics, also no difference with mortality. The last two things I'd like to highlight in my presentation today is it's really important to think about, should delirium be the primary outcome in your clinical study, whether it's a cohort study or a randomized control study. When we think about prevention delirium, this could be incident delirium, ICU days without delirium, time to first delirium episode, duration of first episode of delirium. For treatment of delirium, this could be time to first resolution of delirium, duration of delirium, ICU days without delirium, or severity of delirium. These delirium-related outcomes have been evaluated in all different ways in studies, and there's not really a good consensus about what's most important. But I think, at least in the context of the ICU, as Wes highlighted, yes, delirium in some patients are going to have important clinical signs and symptoms such as fear, hallucinations that can be very bothersome to patients and families. But we're probably more interested, particularly based on, all of the data from brain, ICU, and many other longer term cohort studies really demonstrating the effect of delirium on long-term cognition, but many other potential factors and relationships that really resonate with patients and their families. Shouldn't we be looking at the effect of a delirium reducing intervention on many of these potential outcomes? The last thing is delirium evaluation. And I think this is something that is always a question among delirium researchers. Do you use a validated screening tool or DSM evaluation? If you decide to use a screening tool, do you use a longer form instrument that like diffusion assessment method, which certainly will allow you to strongly identify a phenotype, but it takes a lot of training. So there's feasibility concerns in a larger evaluation of using CAM. One could use a shorter assessment form that's validated, like 4AT, easy to apply, but it doesn't lead to a clear phenotypical definition of the delirium. Who's going to be doing the delirium evaluation? Is it a trained researcher doing it? Is it bedside clinicians? What's the frequency? Is it daily, twice daily? Delirium fluctuates. So there could be someone that's delirium free in the morning. What if they develop delirium in the middle of the night and that's missed? But is a researcher going to be there in the middle of the night screening for delirium? Whereas a bedside clinician like a nurse potentially would be there, but can they be trained to use these screening tools in a valid and reliable fashion? Most studies rely on at least once daily evaluation by a researcher in many cases, and maybe more frequent evaluation by a trained bedside clinician. And then it gets into the degree of training and validation and reliability, because these instruments do require constant training and evaluation for patients. So that's really all I had. Again, these are the 3 key points, and it's important to be thinking about incorporating all of this, of course, not only in your daily clinical care that you provide patients, but also how are you going to account for the use of these sort of best practices in your delirium research endeavors? Thank you.